our agenda, we're going to have some updates, and then from the Health Department and our Maternal Health Task Force, Oklahoma Healthcare Authority, Oklahoma Department of Mental Health and Substance Abuse Services, OPQIC, and then a presentation on our low-dose aspirin and pregnancy campaign. So I think, Joyce, you are up with maternal health updates, and then Jenna Bellantoni is going to provide some information on our maternal mortality and morbidity report.
Great. Thank you, Barbara. Yes, it is that time of year where we try to give an update in relation to maternal health, morbidity, and mortality in our state. So Jenna Bellantoni, our maternal health epidemiologist, will be providing that information to you. This in relation to cases that have been reviewed by the Oklahoma Maternal Mortality Review Committee, as well as other maternal health, morbidity, and mortality data, kind of the most current status as to where we are currently and what the data is telling us in relation to maternal health. So I did want to reference that. She's also going to share some resources at the end of the presentation that we're very happy to include and that everyone will be able to utilize. So with that, I'm going to go ahead and turn it over to Jenna so she can provide that information to you.
Okay, so let me share my screen. And if anyone can just tell me if it's up. Okay, great. So in this presentation, I'm just going to give a brief overview of maternal health Oklahoma using our recent data. As Joyce mentioned, we're going to have our annual maternal health report coming out in November, and so a lot of this information is going to be in there. Okay, so looking at overall health in Oklahoma, so the state has the third highest uninsured rate in the country in 2021 at 16.1%, behind Texas and Alaska. And then according to our 2021 behavioral risk factor surveillance system data, among women 18 to 44 years of age, about 14% reported fair or poor health status, around 18% felt a doctor visit was too costly, 4% had ever received a diabetes diagnosis, 3.2% gestational diabetes, 1.6% had suffered a stroke, 1.2% experiencing a heart attack, a little over 2/3 that had a known BMI were considered overweight or obese. About 16% reported being a current smoker, 11% reported smoking daily, and about 18% reported being a former smoker. Looking at prenatal care initiation in the first trimester, something that we've been trying to increase over time, and it definitely has increased over time, but there definitely are still some geographic variations throughout the state. So this is showing that first trimester prenatal care by county, and those green dots are our birthing hospitals. And so we do see that the counties that have higher percentages of first trimester prenatal care do tend to be those that have a birthing hospital in their county or are close to one. Okay, switching gears, looking at severe maternal morbidity or SMM. So looking from 2020 to 2021, the rate of SMM increased by about 12%, excluding blood transfusions. And looking at specific indicators, the rates of adult respiratory distress syndrome or ARDS, thrombotic embolism, blood transfusion, and ventilation each increased by over 60% from 2020 to 2021, which is indicated in the table by those red boxes. And additionally, about 60% of ARDS and ventilation events also co-occurred with the COVID-19 diagnosis code. Additionally, the rate of eclampsia decreased by approximately 40% from 2020 to 2021. Okay, and there continue to be disparities in SMM with Black and American Indian women having an SMM rate about 1.3 to 1.7 times higher than white women, both including and excluding blood transfusions. Of note for this data, Hispanic origin isn't available, and so SMM by race and ethnicity wasn't evaluated for this time period. And this is looking at 2019 to 2021. Okay, and we also wanted to look at the top causes of SMM by race to highlight specific disparities beyond overall SMM. So ARDS was the leading cause of SMM overall for 2019 to 2021, as well as for American Indian and white women. However, for Black and African American women, that was acute renal failure. So ARDS, acute renal failure, and disseminated intravascular coagulation were in the top 5 causes of SMM overall, and for each racial subgroup. And then additionally, hysterectomy and sepsis were in the top 5 for 2 of the 3 racial subgroups. Okay, moving on to a maternal mortality rate from vital statistics. And this is a 3-year rolling rate just due to the low numbers each year. I'm looking at 2015 to 2021. And we did see a pretty substantial increase in the maternal mortality rate from the 2018 to 2020 time period to the 2019 to 2021 time period. It increased by about 23% from 25.2 to 31.0 maternal deaths per 100,000 live births. And of note, we did see some effects of COVID-19 here. And so we did separate out the deaths that were related to COVID-19 just to visually estimate that effect on the maternal mortality rate. 2021 specifically saw a stark increase in maternal deaths, 35% of which were related to COVID. And for the 2019 to 2021 time period, about 20% of the maternal deaths were related to COVID. Okay, and looking at the maternal mortality rate by race and ethnicity, maternal mortality increased substantially in every race ethnicity group apart from non-Hispanic white women, and particularly increased for non-Hispanic Black women and non-Hispanic American Indian women by 70% and 100%. And the portion of deaths related to COVID-19 also varied by race ethnicity group, with about 38% of deaths among non-Hispanic American Indian women being COVID-related and about 43% of Hispanic women being related to COVID-19. Okay, then moving on to our MMRC reviews. So these charts for the next slides are going to show various characteristics of the deaths reviewed from January 2020 to July 2023. And of note, our annual report that's coming out in November is looking at data through April of 2023, so it will look a little different to the data on these slides today. So among the cases that were reviewed in this time period, about 46% were considered pregnancy related. And of those, nearly 3/4 were considered to be preventable. And the majority, about 60%, occurred in the postpartum period from 1 to 365 days after delivery. Okay, looking at the causes of pregnancy-related deaths from this time period. So a little over half of the pregnancy-related deaths were due to hemorrhage or infection. So for hemorrhage deaths, about half were due to ruptured ectopic pregnancy. And among deaths due to infection, about 43% were due to sepsis and about 30% were due to COVID-19. A little less than half were due to pretty much all the other causes of death, which included amniotic fluid embolism, cardiomyopathy, and hypertensive disorders of pregnancy. So a bit of a smattering. Okay, so the MMRC also makes determinations on factors which contribute to pregnancy-related deaths. So for this time period, for patient or family level contributing factors, the most common were adherence to recommendations, which included pretty much late or no prenatal care and lack of vaccination to COVID-19 and flu, delays in seeking and receiving care, and then substance use disorder. And then looking at the contributing factors at the provider or facility level, the most common factors were clinical skill and quality of care and delay in treatment. Okay, so next we just have some preparing for a lifetime data. And so we're just gonna go over that really quickly. So we have updated our updated numbers for vital statistics for 2022 and PRAMS and TOTS data for 2021. And we are seeing pretty marked improvement for most of our measures, the most drastic of which include teen birth reduction, smoking during pregnancy reduction, and postpartum screening improvement. We do still have some work to do for preterm birth, which is about 5% up from our baseline data. That's still something that we're looking to reduce. Okay, so then lastly, I wanted to just take a minute to talk about our new MCH data portal, which is something that we at Assessment are very excited about. So this data portal, which is the link up here, I can also put it in the chat, will serve as a repository for various maternal and child health data by ways of interactive dashboards, a list of external data sources, and fact sheets, infographics, and reports. Now let's go through those really quickly. If I can get my mouse. Okay, so we have several new interactive dashboards for various domains, including perinatal and reproductive health, child and adolescent health cross-cutting and systems building, which includes data from our state survey systems, PRAMS and TOTS, as well as our MCH county profiles. So I've included a screenshot of our perinatal and reproductive health dashboard to the right of the slide, at which you can see several metrics, including live births, infant deaths, and fetal deaths, where you can select various years and variables to view different kinds of data. Okay, and then next is our list of external data sources. And so it's just a list where you can get more information about various MCH data, which includes the Maternal Health Task Force data catalog, CDC data, census data, Title V data, and various county health data from the state. Okay, and then lastly, our fact sheets, infographics, and reports section serves as a one-stop shop for the various products that are generated by MCH. So included here, just to give a brief overview, is our annual maternal health reports, our PRAMS, GRAMS, WIRE-BS reports, and much more. So pretty much any fact sheet, infographic, or report that we create is going to be here. So if you're looking for something that we produce, it'll be right here in kind of one area. Yeah, this data portal is really a labor of love by the assessment department. So we're really excited about it, and we're really happy that it's available to the public now. And that is all I have. So I don't know if we have any time for questions, but I can answer any questions. I don't know if I can see the chat. Oh, I'm so glad, Caitlin, that it's being used. That's so great to hear.
If anybody has questions, you can chat or come off mute. Yeah, Caitlin says she's been using the new data portal.
Wonderful. That's great news. And thank you, Jenna, for doing the presentation. We did want to share with you, like I said, the latest data. And while you can see from the beginning our maternal mortality rate, we had just started to experience decline before the pandemic hit. Then it went up related to the pandemic. And for 2022, we're starting to see trends that it looks like it appears to be headed in the right direction again. So we're hoping to provide you some better trending data moving forward, but we did want you to have the latest in relation to what was going on in Oklahoma and share that information with you, along with the data portal, so you can look at it, the data, as we go along. Any other questions for Jenna?
Thank you, Jenna.
Thank you.
I will stop sharing. Okay.
Joyce, do you all have any other updates?
I think that is pretty much it, other than we had HRSA come for Maternal Health Innovation site visit. It went very well. They were very impressed with what's going on in Oklahoma, and specifically called out the efforts of the Maternal Health Task Force and Oklahoma Perinatal Quality Improvement Collaborative collaboration throughout the state, as well as some of those efforts, Team Birth, the STAR Clinic, the gap filling maternity clinics throughout the state, and Chest Health, as well as many others involving tribes and other populations. So I did just want to share that with you also. Thank you.
Thank you, Joyce. And up next, we have updates from the Oklahoma Healthcare Authority, Trailer and Heather.
Hi, good evening, everybody. So I'll give a quick update on where we're at with Sooner Select. We're actually having a town hall tomorrow down in Duncan. But we are right in the middle of our implementation work with our medical plans as well as our dental plans. On the dental plan side, letters will start going out to members beginning towards like November the 20th to alert them to open enrollment period, which will start December 1st. So that's right around the corner. Medical and children's specialty open enrollment will start February 1st. And so those letters will go out in January. Everything is looking good right now in terms of implementation, no major hiccups, nothing that gives us concern for an April 1st launch date for medical. Want to give you an update. I know we've talked to this group in the past about our doula coverage, which went live in July. We anticipated kind of a slow uptake with providers, maybe not as much as we're seeing, but I will say I just got back from a national conference and all state Medicaid agencies are seeing the same thing. A general kind of reluctance to contract with the Medicaid agency or any commercial payer that is. So we're kind of pivoting in how we approach the doula provider network in the community on providing more trainings. We did an initial set of webinars to give basic trainings on enrollment and billing, for example, but we're really kind of retooling those and making them more robust so that we can give the providers a more sense of ease in contracting with the healthcare authority and providing those services and seeking reimbursement. Because we know it's important to the moms that are looking for that service. Unfortunately, we have a lot of folks that have interests, but we don't quite have the provider network yet. When I checked earlier today, we have 8 doulas that are contracted, which is up from 2 from last month. So I'll take that as a good. We're getting there. We'll get there, but that is live, and so there's a lot of conversations with various philanthropic organizations to talk about how we can work together and use private and public funds to maybe build capacity throughout the state. And there seems to be an interest there. There's national companies that kind of go from state to state that help set up the doula networks and help them bill and contract and things. But we are considering all options there. And so that's kind of where we're at with that. I have had discussions with the CEOs of our 3 medical plans to talk about how we can leverage some of their resources to help build out the network as well, because prior to us adding coverage, a lot of them had actually already planned on adding it as a value-added benefit anyway. So there's been a desire on their part to utilize this provider type. So there's interest across the board. Other than that, I will give a quick public health emergency unwinding update. We're getting real close to 200,000 individuals that have been unenrolled so far. We're over halfway through the process. Our procedural rate of terminations, which as a reminder, a procedural termination is when we need a full renewal from the individual or the family and they just have failed to update their account. And based on the information known to us at the time, it does not match up with what their attested income, for example, doesn't match up with what our data sources are saying. So we need them to complete a full renewal. And when we don't get that, we have to terminate. So we've taken some strategies over the last few months, such as pausing procedural terminations for 30 days to allow us more time to do some outreach with those families. That's resulted in about 5,000 members maintaining their coverage. We are seeing overall a decline in the number of non-renewals or terminations at the end of the month. So I think for the last month, we haven't published it yet, but it was close to 15,000 members lost their eligibility, which is down from about 30,000 a month. We're still trying to dig in and see what that tells us. But what we're kind of guessing is we're seeing a lot more folks actively renew because we were planning to have closer to 30,000 this month as well. We're getting to that point where I call it, we're getting to the part where it hurts, because as you'll recall, those first few months were those folks that were way over income, had third-party liability through commercial coverage, had never used the program, and didn't meet certain criteria that would demonstrate to us that they needed and were relying on the program. So we're to the point now where it is those members that have young kiddos in the family, maybe have chronic conditions, multiple conditions or prescriptions that they need filled. And so we kind of expected to see a lower rate of unwinding as we get closer, because folks are taking active steps to renew their accounts. But it's going as planned. We are working with a company called Unite Us. You may be familiar with the name. They do some social coordination of services, and they have a platform for that. But what we're using them for is specifically for PHE unwinding. So those roughly 15,000 to 30,000 members every month that we're unenrolling, we're giving those files over to Unite Us, so then they can put them through kind of a data analytics engine, determine the level of care coordination needed based on information known in their system, so that they can either do something a light touch like a text message, or they may even receive a call or a care coordination visit to really make sure the member's connected to care. We know that they may not be eligible for Sooner Care anymore, but we want to make sure they still have access to free or reduced cost services such as an FQHC or a CMHC. And so Unite Us is helping us make sure that those members have that level of care coordination to receive the services they still need, even if they don't have coverage. I think we did also send, just as an update, we sent out a postcard to every pregnant individual on our file that we show as having a pregnancy indicator, they got a postcard just to remind them that we have 12 months of postpartum coverage, and then gave them a link to the resources back to our website to say what is covered during that period, how to utilize those services, and just making sure they know what all is available and that their coverage doesn't end at the end of pregnancy. So we really try to advertise that and just get the word out so that these moms know that their coverage doesn't end at birth or that 60-day period after birth. Also working with Joyce and folks on the low dose aspirin and publicizing, the webinars around that, and really trying to help get the word out with that initiative as well. But lots of stuff going on. Yeah, happy to take any questions.
Thanks, Trailer. Anyone have questions for Trailer? I'm curious, Trailer, the cards that you mentioned that you're sending to ensure they're informed about the postpartum coverage, could we receive that and we could send it out to, and maybe as we talk to providers, give them some too, that maybe they could have in their clinics to make sure that they, as they're going to clinic visits, that they could inform them as well.
Sure, I can get you the mock-up. It's a front and back card, but it ends up being a 2-sheet PDF. But we can get you something that's maybe more of a flyer, if you will, that people can post for sure.
Yeah, I'm thinking that could be a way that we share that.
Yeah. And just as you spoke up, Barbara, made me think too, as a reminder to this group, part of the legislation that required the move to Sooner Select also required that we have a quality advisory committee that advises the healthcare authority on certain quality measures related specifically to our Sooner Select program. So this is helping set baseline measures for us to measure, holding plans accountable once we start getting quality feedback from them on their performance. And then really just a group to help advise us, and if we're going in the right direction, how we need to maybe adjust some of those measures over time, and overall advise us on the Sooner Select service delivery system. And Barbara is a member of that quality advisory committee, so we're happy to have her there to share her expertise in this space. So
thank you.
Trailer, would we be able to get the postcards too for our county health departments?
yeah, you bet. I'll get you connected with our comms.
Or a flyer?
Yeah,
Sure.
whatever. Thank you, Trailer. And if there's no questions for Trailer, I will turn it over to Heather Cox.
Oh, I was on mute, sorry. Thank you, Trailer, for that. He's always a tough act to follow. My name is Heather Cox. I'm a manager of policy with the Oklahoma Healthcare Authority. And thank you to this collaborative for giving me this opportunity to speak with you all. I'm going to try to keep this short and relatively informational. The purpose of this presentation is due to federal regulations that require the state to annually report on the progress of our 1115 waiver, otherwise known as Sooner Care Choice. This presentation is known as the post-award forum, and it's intended to give the public an opportunity to provide feedback, and we give an update on the demonstration, including patient-centered medical homes, also known as PCMH, HON, HMP, and Insure Oklahoma. A posting for soliciting feedback was placed on our website on September 19th, and we'll keep that open for, I think, until November 19th. Next slide, please. And I think, actually, that was the right slide, but it's okay. Thank you. Oklahoma's Sooner Care Choice program operates under an enhanced primary care case management delivery system to serve qualified populations statewide. The healthcare authority contracts directly with primary care providers to serve as patient-centered medical homes. The Sooner Care Choice program promotes the goals of providing accessible, high quality, and cost-effective care to Sooner Care Choice members. In addition, the 1115 research and demonstration waiver provides the authority for our Insure Oklahoma program, which is a premium assistance program for qualifying Oklahomans. Next slide. Sorry, I can hear my dog in the background, and I'm hoping she's relatively quiet. Okay, next slide. During calendar year 2022, we did not submit any new waivers. The two previous amendments that we submitted in 2021 remain on hold. Next slide. Next slide. Okay. During 2022, one of the key challenges that remained was the state's pursuit of a third-party managed care delivery system. Initially, we had planned to take the 1115 waiver authority route, but we decided to pivot and we utilized the 1915 route instead, which turned out to be a very successful choice because we recently got CMS approval of the waiver to implement managed care. Another challenge was the COVID-19 public health emergency. It remained a challenge because of the frequent renewals and anticipation, preparing for unwinding, and so forth. But that is finally coming to an end. In 2022, the state revised the metrics for the Payment for Excellence program. There was some back and forth with CMS that proved to be somewhat challenging, but beginning in the first quarter of 2022, payments and provider scorecards were provided and demonstrated providers' performance on all incentive measures. Next slide. So 2022 was the first full calendar year of Oklahoma's newly expanded Medicaid program. As of December 2022, more than 350,000 people have been enrolled. So I would definitely call that an achievement. At the end of 2022, we submitted a renewal request to continue our Sooner Care Choice waiver for another 5 years. We received verbal approval for 1 year, so 2024 through 2025. The renewal application will be applied to the next period for 2025 through 2030. Next slide. Next slide. Okay, so this slide shows you the enrollment numbers for Sooner Care Choice over calendar year 2022. You'll notice how it trends up each month. This is due to the continuous enrollment provision of the PHE, where the state could not disenroll anyone due to most changes in circumstances. Next slide. Okay, so I am more of a words person, not a numbers person, but I feel like these numbers here speak for themselves. Oklahoma processed 100% of applications within 24 hours, and we had the second lowest perm rate in the nation. And you see that the lowest claim processing error rate, that's what perm is, payment error rate measure. So 0, that's great. Next, please. Okay, so this chart shows the top 10 categories based on expenditure. What it doesn't show, but can be found in our evaluation report, is that access to primary care among children and adolescents in Sooner Care Choice was higher than the comparison group by a statistically significant amount. Can't say that word. All right, next slide, please. Okay, yeah, this one. The all 1115 demonstration waivers must be budget neutral, meaning that the program shall not cost the federal government more than what it would have otherwise absent the demonstration. So despite the increase in overall Sooner Care enrollment numbers due to the PHE and not being able to disenroll people, our budget neutrality figures remained similar to the previous year. Next slide. So our agency partners with an independent evaluator. PHPG stands for Pacific Health Policy Group. Each year, they review the program cost effectiveness through utilization expenditures, including the rate of emergency room visits, inpatient hospital admission, utilization, as well as the per member per month healthcare expenditures. PHPG conducts member satisfaction surveys to monitor how we are doing and find ways that we can improve. This chart shows the components that are measured and considered for each program type. Next slide, please. Okay, looking forward. So an independent evaluator in partnership with our agency, we'll develop an evaluation design utilizing the data from 2022. That's going forward. The Sooner Care Choice waiver should be renewed, as I said previously, will be renewed for another 5 years in 2025. We'll have new STCs, which is the standard terms and conditions, I believe, based on approved amendments that we will have submitted by then. And of course, we are looking forward to, as Traylor said, the rollout of the managed care model in early 2024. I broke that down by program, but he already covered that. So, okay, next slide. I think we're at the end. Yes, so thank you all for listening to me give you this update. If you have any feedback, you can put it in the chat here, or you can email federal authorities at OPQIC.org. And the full report with all the fun facts and figures, if that's interesting to you, is available on our policy blog. Thank you.
Thank you, Heather. Appreciate that, sharing that information. And if others have feedback they'd like to share, here are the ways to do that. And we will be providing you with these slides and recording after the meeting, anyone who attended.
Awesome. Thank you.
Thanks, Heather. And next, Teresa Stevenson.
Hello, I don't have any PowerPoints for you today, but really just kind of updating on our Tough as a Mother anti-stigma campaign work that we're doing. We're really expanding the training opportunities for that. And so if each of you have a group that you meet with regularly that would like additional training or understanding of the Tough as a Mother anti-stigma campaign, and of course the family care plan and Storyvine, which helps people to tell their story, you know, please contact me and we will get with you to provide that so that we can get the word out and have more people understand what it's about, how it can help individuals that are pregnant or have children, and they also have a substance use disorder. So really we can help to promote them receiving treatment early on in their pregnancy or before pregnancy, so we can reduce the potential of criminal and deprived involvement. However, that doesn't mean that they have to have done this during pregnancy or before they're involved in the system. If they're already involved in the system, we definitely want to be a part of that work and support them to hopefully regain custody of their children if that's the most appropriate. I did have a meeting with DHS yesterday with Dr. Shropshire and Trish Howell and Debbie Connect to talk about the potential pilot study for 2 to 3 individuals that were exposed with methamphetamine that have gone through the STAR clinic, which is the prenatal substance use clinic that we have in Oklahoma County. And if that is of any interest, to be able to do a pilot where they would allow the child and mother stay together to go from birthing hospital to a women with children residential facility, and then also to go into a higher level recovery residence that the baby and the mom could stay together. And it's a potential opportunity of what that would look like, so that we can really look what that process would look like, what supports are needed, what what else do we need to add to help these families stay together, to reduce ACE scores at birth. And so it wasn't a hard no. There are obviously some other logistics that would come in that, and conversations that would come into play with our DA, the Women with Children Residential Facility, the STAR Clinic, and DHS. So they are going to actually reach out to the Oklahoma County DA to just have a conversation about if this is even a potential. Because right now, the way that operates, I wouldn't say all, but a large percentage of individuals that have methamphetamine or a stimulant use disorder tend to have, I would say, automatic out-of-home placement. It's not all the time, so I don't want to make it seem like an absolute, but it does happen often because they're so fearful of the safety of the home environment for that child. However, it's not, it's not kind of like it was back in the day when we had, meth homes and things like that. However, so that's just something that's coming about and we're having conversations with. We do really want to see families be able to stay together if they are at all possible and it's still a safe environment and we can put, we know we can't control for 100% of variables, but if we can put into place a lot of these supports across the continuum, and that includes like our parent-child assistance program, 3 years postpartum, that can be there to support that individual too. So that's happening, or that's still in process, but having conversations about that. And then of course, we would love everyone to save the date. It will be a small group of individuals that will be invited to the Family Preservation Summit in March 7th. It's March 7th. We're probably going to invite about 200 individuals, but that summit in itself will be looking at different ways different pathways to help individuals reduce the potential of criminal and deprived involvement, especially criminal involvement due to their substance use, whether they're pregnant with a substance use, or maybe they have just had a child with substance use, or maybe they had, a demise or a stillbirth and they were exposed to substances. We're seeing, that increase of criminal involvement as due to substance use related pregnancies. And so we really want to find alternatives, like what can we do to help wrap services around these families to help protect them from, potential incarceration or felony neglect charges, things of that nature. And then we have our Momentum Conference that's December 5th through the 7th. And we hope that all of you will join us as a part of that conference. We really have a great lineup for that conference, and that includes our Justice Prevention and Recovery Conference this year. Usually that's separated out, but for this year we have combined that, and that's probably how it will be from here on out. And so that's why it's 3 days long. Very excited about that. And then I did speak just recently at our OPQIC conference, which is for those opioid treatment providers, which primarily they are what we would consider a methadone clinic. And there is a lot of stigma and conversation around methadone clinics in Oklahoma right now. And with the increased use of fentanyl as a choice of drug, or just being exposed to fentanyl, the other drugs may not quite meet that need. And so there's always going to be a need for methadone. And so we really, I'm sorry, did somebody have something to say something? So the need for methadone is always going to need to exist, and it may even need to be expanded for those persons that regularly use fentanyl. So really helping to break down the stigma, help people understand methadone and how well it is regulated is something that we're going to be continuing to work on as well. And that's really all I have right now.
Thank you, Teresa. We appreciate those updates. I am going to provide a few updates from OPQIC. First of all, Denise, if you'll go to the next slide. Wanted to make sure everyone is aware of our pre-summit that we're going to be having on November 16th and our OPQIC summit on November 17th. So the pre-summit will feature Krista Dancy, who specializes in care for professionals who have experienced a difficult clinical experience and how to cope and heal. So that is going to be in the afternoon on November 16th from 1 o'clock to 4 o'clock. registration begins at 12:30. So you have a link here and a QR code. You can go to our website to register for that and for the OPQIC Summit, which will be the next day on November 17th from 9 o'clock to 4 o'clock. Registration begins at 8:30. We will have breakfast and lunch served, and highlights of the agenda: neonatal therapeutic hypothermia, low-dose aspirin, OB emergency readiness for the emergency department, a doula panel, and maternal mental health. So we hope that everyone registers and attends the pre-summit and the summit. So spread the word. Next slide. I wanted to announce we did learn yesterday we received a $20,000 grant from AIM. This will be used for OB obstetric patient safety workshops for emergency department providers across Oklahoma. So we're thankful to AIM for that funding. And next slide, wanted to provide you with some updates on teen birth data. This is data through the end of August. First of all, our hospitals. As a reminder, we had first our pilot hospital, St. Francis in Tulsa, and then the hospital supported by George Kaiser Family Foundation in Tulsa, Hillcrest, and OSU. And then all of the different cohort hospitals are those that are supported by the OPQIC statewide teen birth initiative, supported by HRSA and OSDH funding. So we're appreciative of that. And if you go to the next slide, we have 34 out of our 44 birthing hospitals that are participating in teen birth. And we just finished cohort 2, just finished last week, I guess, submitting data for the research. So we have 2 more cohorts. Cohort 4 is going to launch on November 1st and 2nd. And I am receiving information from other hospitals that haven't joined our cohorts. Hey, how can we do this? So we'll figure out how to help them implement teen birth as well. So to share a little bit of data with you, this is again through August, and the data here is these are from patient surveys that are distributed after during the postpartum stay in the hospital, and patients complete these surveys either via paper or a QR code. So the first one is some questions that are from the mother's autonomy in decision making. And you can see here for those that said they did not experience a huddle versus those who experienced a huddle, you can see the rate of high autonomy increased by 20 percentage points. So that's a pretty significant difference. And those with a moderate autonomy decreased from 22% to 9%. And there were also decreases in the others. So big difference in the autonomy and decision-making skills on whether someone had a huddle or not. And we use that as whether they experienced teen birth. The next data shows these, the previous data broken down by race and ethnicity. So you can see each category at the bottom for race or ethnicity has a no, those patients who did not experience teen birth versus those who did. And you can see that pretty much for every different group, they had, again, a 20 percentage point of around a 20 percentage point increase in their autonomy, having high autonomy, saying they had high autonomy. The most increase was from the non-Hispanic Asian group, from 50% to 84%. But you can see the numbers are lower in that group as well. And then certainly also with the non-Hispanic multiracial, we had a large increase there. So this is very promising from the autonomy data. When we look at the next slide, we're using a different questions that are from the healthcare relationship trust scale. And so you can see here, these are no huddle versus yes huddle. And the first question here, discussed options and choices before making healthcare decisions. And these percentages are those who said all the time by labor huddle status from all of our cohorts. That first question is always the lowest for every hospital. And we anticipated that sometimes the options and choices are not, patients are not hearing that they are discussed as often as the other questions here. So you can read the questions at the bottom. These are both from validated scales, and the next slide has some more scales from the healthcare relationship trust scale items. But for every question, those who answered all the time, there is a significant increase for those. We are looking at the data there. We will have all of our data complete by June the 30th. And so they're anticipating manuscript that will be published hopefully at the end of next year. So these are very promising data, and wanted to know if there was any questions that anyone has about teen birth. Okay, next slide. I'll turn it over to Melissa, who is going to share information about our low-dose aspirin initiative. And Melissa Ward is a new staff member of ours, and she is not, this is her first quarterly meeting. She is leading this project in our state and joined our team in May. So I'll turn it over to you, Melissa.
All right, thank you, Barbara. Yes, I'll be covering our low-dose aspirin campaign today to reduce rates of preeclampsia and improve birth outcomes in Oklahoma. So first of all, I want to acknowledge the George Kaiser Family Foundation for providing funding for this project. And so today I'm going to discuss the current state of preeclampsia and preterm birth, define exactly what preeclampsia is, discuss low-dose aspirin and how it can help prevent preeclampsia, show the guidelines for low-dose aspirin, what our project goals are, share our toolkit with the group, discuss our public awareness campaign, and then I'll open it up for a question and answer session. So just some quick stats. So worldwide and in the US, preeclampsia is a leading contributor to severe maternal morbidity and maternal death. Some recent data I got from OHCA was that from 7/1/22 to 6/30/2023, so kind of when we were beginning this project, we wanted to set a baseline data point. There were 2,445 sooner care patients diagnosed with preeclampsia and 108 cases of eclampsia. And of course, preeclampsia is responsible for 6% of all medically indicated early preterm births, so those that occur before 34 weeks, and 19% of preterm births are those that occur before 37 weeks. In Oklahoma, we rank as one of the worst in the nation, with our preterm birth rate being 11.9%, and that is 45% higher in Black women, although I think I saw from Jenna's presentation it might be higher than that now. And of course, we're in a maternity care desert, so a lot of people do not have quick access to an appointment, especially if they need to see a high-risk physician. Yes, so the distance to the appointment, and then of course you have to take time off work to travel. And if you're somebody who works an hourly wage job, that can be challenging. And then of course, if there's an emergency, where do you go? Access can be lacking. There's also a high risk for cardiovascular diseases that develop later in life after preeclampsia. And in Oklahoma, 1 woman dies every month and 70 more have life-threatening complications related to childbirth. So what is preeclampsia exactly? Well, it does go by many names. Sometimes those names are used interchangeably. It's been referred to as toxemia or gestational hypertension, which is a sudden onset of hypertension after 20 weeks of pregnancy. Superimposed preeclampsia, so that is if the patient has chronic hypertension going into the pregnancy and then they get preeclampsia on top of that. It's also in severe cases accompanied by HELLP syndrome, which affects the liver. But most commonly, we characterize preeclampsia itself as a blood pressure of 140/90 or greater and proteinuria, which can signify that your kidney is having to work too hard. And as for physical symptoms, patients may have a headache that doesn't go away, or swelling in the hands, legs, or face. But it's important to note that some patients don't experience any of these symptoms at all, so it's critical that they get frequent prenatal appointments, especially if they're high risk. And preeclampsia in the pregnant individual can lead to kidney, liver, or brain damage, blood clots, postpartum hemorrhage, eclampsia, stroke, or death. And some of the pregnancy complications include preterm birth, placental abruption, fetal growth restriction, and low birth weight. It's also important to note that preeclampsia can occur in the postpartum period, but for purposes of this project, we are only focusing on the prenatal period. So what causes preeclampsia exactly? Well, it is thought, and I believe thought is the key word because there's still a lot of research that is being done in this field to try to figure out who is going to get preeclampsia and who will not, because sometimes this can be difficult to predict. Ultimately, it's that the placenta does not form correctly as it is developing. And so that could be due to a number of issues, but I think the picture on the left summarizes it the best. So you have these spiral arteries that form throughout the pregnancy and dilate to accommodate for extra blood flow, which provides oxygen and nutrients to the fetus. But in the case of preeclampsia, those spiral arteries do not dilate as they should. This creates inflammation. And then, of course, you've got all this extra blood volume while you're pregnant, and it kind of gets stuck in these passageways. So it could form, blood clots or things like that, and it reduces the amount of oxygen and nutrients that can get to the fetus. So we want to focus on preventing preeclampsia before it happens, or at least delaying the onset of it, so that way the patient can get to a full-term pregnancy. So as I mentioned, there are some short-term effects of preeclampsia, it being the leading contributor to severe maternal morbidity and maternal death, and then those fetal infant complications, some of which can last a lifetime. Fetal growth restriction, intrauterine fetal demise, low birth weight, preterm birth, infant death. And then the long-term effects of preeclampsia on the mother. So your likelihood of developing chronic hypertension is greater than 50% on average 14 years after you've had preeclampsia. So if you think of somebody who got preeclampsia at 20 years old, by their mid-30s, they could already be dealing with chronic hypertension. There's also a 2 times greater risk of death from cardiovascular disease. And in those patients that develop preeclampsia before 34 weeks, they have a 4 to 8 times higher risk of death. There's also the increased risk of metabolic syndrome or chronic or end-stage renal disease. And right now, we still don't know if preeclampsia itself is a predictor of cardiovascular disease or if it's what causes it in the first place. So low-dose aspirin, how does it work exactly? Well, it is an anti-inflammatory and an antiplatelet drug, meaning it reduces the stickiness of your red blood cells. And so its method of action is to inhibit key enzymes that line the blood vessels. So the COX-1 enzyme lines the inner surface and regulates two types of prostaglandins, prostacyclin, which is a vasodilator and allows your blood vessels to expand, and thromboxane, which is a vasoconstrictor, which causes them to shrink. In the case of low-dose aspirin, it inhibits COX-1's enzyme's ability to produce thromboxane, so that vasoconstrictor, but it does not affect the prostacyclin. So it helps those spiral arteries dilate throughout to allow for growth of the fetus throughout the pregnancy. And key to note is that a systematic review process revealed no maternal or fetal risks associated with low-dose aspirin. As a matter of fact, research on low-dose aspirin and preeclampsia, the first study was done in 1978. So we actually have 45 years worth of research that people have done about how it can reduce rates of preeclampsia. And so this led the United States Preventative Services Task Force to issue a final recommendation statement in 2021, where they reviewed quality studies on low-dose aspirin, and they found that it significantly reduced rates of preeclampsia, perinatal mortality, preterm birth, and fetal growth restriction. Yet, despite these recommendations, there was an article that came out in August of just this year that showed that low-dose aspirin is being used in less than 50% of high risk and less than 25% of patients with more than one moderate risk factor. And patient surveys indicate only 58% of high risk and 5% of moderate risk patients recalled someone even telling them to take aspirin. So the low rates of use could be due to a number of reasons. So one, low rates of prescribers recommending low-dose aspirin. I mentioned that guideline came out in 2021. Of course, we're in the height of COVID during that time, so it's very possible it got buried in all the other recommendations for COVID that were going on. Patients don't remember receiving a recommendation. This is entirely possible if a patient is told to go purchase it OTC. I mentioned many patients have to take time off work to go do that, so they may be rushing back and not go buy it right away. And so there could be a delay in starting aspirin therapy. And then, of course, patients may be hesitant to take it. I know we hear a lot about aspirin. There's always a study coming out saying aspirin helps with this. No, aspirin doesn't help with that. It can be really confusing information. And, you know, patients are hesitant to do anything that may harm their babies, and that's completely understandable. So we need to take appropriate interventions along the care continuum to make sure that they are properly informed that aspirin can be beneficial for them during a pregnancy. So the goal of this project is to reduce rates of preeclampsia and improve birth outcomes in Oklahoma by increasing rates of low-dose aspirin usage during pregnancy. The scope of this project is to ensure providers have access to the most current guidelines and are prescribing aspirin to those who need it, providing education and informational materials that target all types of different caregivers, clinical or otherwise. And then a public awareness campaign regarding the benefits of aspirin that targets the general population. So not just people who are pregnant or planning on getting pregnant, but also their friends and family members, because we know a lot of people seek out the advice of their friends and family when it comes to medical things. So what are the most up-to-date guidelines? So if you look at this is the one that was put out by USPSTF. The high risk factors are not particularly surprising because history of preeclampsia in a previous pregnancy, especially if it resulted in an adverse outcome, pregnant with twins or triplets, you already have chronic hypertension or type 1 or 2 diabetes, kidney disease, autoimmune disease. But note the thing where it says combinations of multiple moderate risk factors. So on the right column, it says recommend low-dose aspirin if the patient has 2 or more moderate risk factors. And I think these are very interesting because there's a lot of nuance to it all. So one nulliparity. So this is the first time you've ever had a child, just due to the nature of preeclampsia, and sometimes it is difficult to predict. This could be a moderate risk factor for a patient. Obesity, greater than 30 BMI. Family history, so your mom or sister had it. And I'm going to skip over the next two, I'll come back to that. Age 35 or older, and personal history factors such as you were a small baby, or you had a previous adverse pregnancy outcome, or it's been over 10 years since you had a baby. So some of the additions, so in vitro conception was one of the ones that was added in 2021, but also previously sociodemographic factors were combined into one column, and know that now they are two separate things. So we know that Black individuals experience more mortality and morbidity episodes compared to white persons. And this could be due to a number of reasons. A lot of them, you know, your environment that you're living in, different environmental stressors. But there have been several high-profile celebrities, such as Beyonce, who got preeclampsia, or Olympian Allison Felix, or even this summer, we experienced the loss of Tori Bowie, also an Olympian who died of eclampsia alone in her apartment. These are some women that had access to some of the best care in the world, but they still experienced adverse outcomes. As a matter of fact, there was a survey that came out by the CDC recently that said about 30% of Black and Hispanic mothers reported mistreatment during maternity care. So it could be just delay of seeking care because experiences in the past have been poor. In addition, we have low income. So we discussed that we have a maternity care desert here. We also have a childcare desert in Oklahoma. So we may have a lot of families where there's just one person working. They could be lower income, working those hourly wage jobs. When you are low income, there's that much more stress that goes into how am I going to pay my bills? How am I going to pay for childcare? And these really can affect you on a physiological level. And so that has been identified as a risk factor for preeclampsia. And so when you think about this, it's kind of a game of mix and match. So if this is the first time you've ever had a baby, you're 35, you would be considered high risk based on this. I think most people on this call could think of somebody that would meet the criteria for taking aspirin during their pregnancy, based on a combination of moderate risk factors or even some of the high risk factors. It's also important to note that your likelihood can also be influenced by paternal factors, but I'm not going to really go too much into that right now. So how to take aspirin. So aspirin is generally recommended to be started between 12 and 16 weeks of gestation. However, the new guidelines suggest that it can be initiated anytime between 12 and 28 weeks. And it's take one tablet every day at bedtime until birth. We are recommending that providers send an electronic prescription for this. For one, it does improve medication reconciliation. Some feedback we've received is that usually it's just a notation in the patient's chart that they were told to take aspirin. So that may not be something that's necessarily followed up on. I know when I go to the doctor, they always say, are you still taking this? Are you still taking that? Aspirin should be right up there with the rest of the prescription medications, so we can make sure that we're asking about that at each appointment. It's key to note that for aspirin to work, it does need to be taken greater than 90% of the time. And so if a patient is not adherent to their medication, it's not going to work. That's why it's important to have multiple interventions over the course of the pregnancy. Also, OHCA will now pay for 100 tablets of low-dose aspirin, and that is only in women who are of childbearing age, and that is for the prevention of preeclampsia in pregnant persons. So that'll be supplied to them at no cost. It's also available for most commercial plans. And for patients who don't have insurance, or maybe they don't want to use a punch to pay for it, it generally is still very low cost when you buy it as a prescription. I actually looked at Walgreens, for example, it was $4 to get 100 tablets. So it is possible to get it pretty cheap. Some alternative options, which classically these have been used the most, so instructing the patient to buy it at the drugstore. Some issues with this, again, are timeliness of the purchase. So did they go straight from the doctor's office to the drugstore or grocery store to go buy it? And what does follow-up look like with that? How is that medication inputted into that patient's chart so we can ensure we're checking in with them at each visit? The cost barrier, there's also an overwhelming number of options to purchase aspirin, OTC at the pharmacy. And so the sheer number of choices may overwhelm someone. And then, of course, there's the labeling aspect. So it used to say on the OTC bottle, do not take while pregnant. Now it says, do not take in your 3rd trimester of pregnancy unless you definitely were told to take it by your provider. And so that could be just very confusing for people. And so we want to make sure we're providing some clarity on how to take aspirin. So you can see an example prescription on the side, take it every night or at bedtime for the prevention of preeclampsia, discontinue until when the baby's born. Another option is to provide aspirin on site, but looking into this, it is rather difficult to do unless you just go and buy it on your own, but there are a lot of requirements and quality tracking measures that are involved in that. So it could be a little bit time consuming. So now I will share our OB/GYN practice toolkit. So this toolkit, and I'm sure other clinics may come up with some ideas on their own, especially as they leverage their EHR systems more. But these are designed to just help you get started in a QI. I'm not sure what the word I'm looking at. A QI. If you are wanting to improve your processes in your own clinic, let's put it like that. So the first sheet is for patients to fill out. So at your first prenatal appointment, there's several forms that you fill out. This could be one of them. This is written in a 4th to 8th grade reading level. It's available in both English and Spanish, as are all the other patient materials. And this simplifies some of the medical jargon that, so it's easier to understand for patients. So do you have high blood pressure? Do you have diabetes? Do you have problems with your kidneys? And then, so the patient would check off these boxes, and it says, if you checked one or more, talk to your provider to see if low-dose aspirin can help you. And then there's a little blurb on the bottom about why aspirin is beneficial. Then we have the screening form that a nurse could fill out. I've seen a PDSA that came out recently through the University of Wisconsin, and it is on our live binder if you want to check that out. Nurses took complete ownership of screening patients for preeclampsia and then involved the provider when that patient screened positive for intervention. And so again, it identifies if patients are high risk or moderate risk. A low-risk patient would be somebody who had a previous uncomplicated delivery. And this could be scanned as media to the patient's profile. And then we have a decision tree for providers to decide, would this patient be eligible for aspirin? Is the patient 12 weeks or less than pregnant, or are they greater than that? So it just kind of gives you some guidelines to go by and some recommendations. So let's talk about the patient toolkit, because we can recommend aspirin all day, but if our patients aren't taking it and they're not informed about why they're supposed to be taking it, then you're never going to really see the true benefit of it. So we do have some informational posters that we are providing to clinics, but you can also print them out on your own. So how can aspirin keep you and your baby safe? So these could be hung in elevators, waiting rooms, clinic rooms, and it directs patients on this QR code to the preeclampsia website. They have a great informational video that's available in English and Spanish that talks about why aspirin would be prescribed, and they've got some other helpful materials on there. And then patient tools, this trifold brochure. So this would ideally be provided to the patient once they're told to take it. So it tells you about what preeclampsia or eclampsia is, what are the signs and symptoms, how can aspirin help, and how to take it. And then for waiting rooms, we have these brochures. As I mentioned before, many people may be just hanging out in the waiting room, waiting to see a provider for a number of reasons. And so just having these out there for anybody to read can kind of help build that public awareness. And then we have our Track My Meds calendar. So this is completely optional for people to use. I know there's a multitude of ways that people may find best for themselves, whether it be setting an alarm on their phone, if they use pill minders, if they use a pill reminder app. But this is just something they could take to their bathroom mirror and then just check off each day that they're taking their medication. It's just one way to kind of help patients be more adherent, because we know not everybody has access to apps if they're using a government phone, things like that. So just whatever we can do to help get that patient to that 90% adherence level. And so ideally, this is what that clinic workflow would look like. So the patient would complete that first screening form. The nurse would complete the screening form with the patient or ask their score. The provider would then discuss that aspirin eligibility with patient and explain what it does, and then hand them that brochure that they can take home and read more about it later on. I know we get completely overwhelmed sometimes, especially in these initial prenatal appointments when you're, hearing your baby's heartbeat for the first time and discussing all kinds of other things. And so it's important to have something that they can take home and read about later. Then ideally, that provider would e-scribe the medication to the patient's preferred pharmacy. In the next phase, the patient would attend their other prenatal appointments. The nurse would complete that medication reconciliation at each visit and identify if there are any barriers to adoption. And then the provider would ask the patient about their concerns. This is also a great opportunity to include those doulas, especially the prenatal doulas, in the continuum of care, because we know a lot of these doulas, especially for Medicaid patients, they're caring for our most vulnerable populations. So it's important that they be in the loop and kind of direct those patients to resources if they have questions. And then the final stage, that patient shows up for delivery and they are asked by our labor and delivery nurses if they're taking prenatal vitamins and aspirin use during pregnancy. So now I'll move on to our public awareness campaign. And so this is a partnership we have with OSDH, and they have created some great materials that they are distributing on their social medias with the hashtag #AskAboutAspirin. So this first one over here is something that is being distributed on social media. And these other ones right here, these are what are called banner ads. So if you ever read a news article and you see these little ads on the side or the top, that's what those are. So anybody could click on that. And then they have some television PSAs that are going out. So you may see a commercial about aspirin therapy and aspirin use during pregnancy. OPQIC is also running our own social media campaign. So this middle one right here is the first one that went out a couple days ago. We've already reached, it's updated since then, 20,000 people with this first initial ad. So it just explains what preeclampsia is, what conditions it could cause, and how low dose aspirin could help. These are some future mock-ups that we may be running in the next couple months. So every month we'll focus on a new kind of subject around low dose aspirin and preeclampsia. And then, of course, we have our clinician awareness campaign. So coming up at the end of this month, we will have a moderated educational webinar where I'll be sharing many of the things that you just heard, but also kind of walk through a clinic through how do you do quality improvement and what kind of questions you have to ask yourself when you're thinking about focusing on low dose aspirin in particular. So please share that. It is up on our social media. We've also been featured in multiple newsletters across the state. So TCI, we were also featured in the OHCA provider and patient newsletter, the Oklahoma physician assistant newsletter, the Oklahoma Nurse Association, COBA, and the Tulsa Health Department. Of course, all those posters, brochures, and clinical tools are printed, can be printed and available for use, but I also have a bunch too that I've already printed. So that is something you're interested in, please reach out to me. And I'm also happy to schedule time with you all if you'd like me to come in and talk about this initiative with your team and share some of these quality improvement tools. And you can always email me to set up a meeting with your group. And now that I'm officially hoarse from all that talking, you can go ahead and ask me any questions that you have. If you'd like to access our live binder, you can scan this QR code or you can visit our website. And with that, I'll open it up for questions and discussion.
Anybody have questions? I know Amy Allen from OHCA had maybe some clarifying information about the prescriptions. Amy, do you want to share? I know she's looking that up, but we'll.
Sure, I'd be happy to. I know that if you have a diagnosis of preeclampsia, then OHCA Sooner Care will cover for members that medication, but you do have to have a prescription from a doctor. And I was just also sharing that, you know, there's only 6 prescriptions a month that a mom or members can get. And so one of the ways, you know, is if you have your providers go ahead and write that out for 90 days worth, that'll probably get you through most of the rest of your pregnancy, I would think.
Yeah.
And that you could get a prescription of that, and then that would just be one of your prescriptions for the month, and you wouldn't have to use it next month then to cover
Right.
one of the medications.
Yeah, absolutely. And it is for 100 days. And they actually have that on their worksheet, because I thought that was unusual too, because if you've ever worked in pharmacy, everything is like 30, 60, 90, right? And so, but in this case, they pay for 100 tablets. And yeah, it would be pretty much good for a majority of your pregnancy at least. Now, if you were taking it, let's say you started at 12 weeks, you still got, 6 months of pregnancy to go. And so it's possible that you may need to supplement that prescription at another time. As I shared before, it is pretty low cost, even through a prescription, if your insurance doesn't cover it as well. So
Amy, my question is if they get the one prescription and say they start at 12 weeks and they get the one prescription, can they get another prescription for aspirin later in pregnancy? Because that they would need around 270 days of the supply. Do you know if they can get another prescription?
Looking on the letter, I don't see where it's limiting it on that, but Melissa said something about only getting 100 of those. Is that something?
So in the case of Sooner Care patients, yeah, they get 100 paid for, and then anything that they would need after that point, they would probably have to pay cash price for. Again, it is very low cost to get that medication. Hopefully, I have the audience of OHCA on here right now, so maybe we'll push for that in the future to get some additional refills filled for patients. But yeah, so they would still have to probably purchase more later on.
I did send a letter to you, Barbara, the provider letter, and it just says 1 a day. So I'm not sure 100% on the question you did ask me about.
Okay, we'll check on that. If they can do another prescription or if it is only for the one.
I can get back with you on it and visit with the pharmacy
Yeah,
about it if you'd
check.
like.
Amy, that would be great. And just let
Sure.
us. So we'll make sure we have that information. Mindy was curious if OB/GYNs are allowed to dispense OTC aspirin, or do patients have to go to a pharmacy?
I would say you absolutely could. I mean, in an ideal world, yes, we would be distributing at physician clinics. I did try to reach out to Bayer multiple times through various avenues to see if that was something that could be possible, but I didn't really get any kind of response from them. I also spoke with some other groups who have done low dose aspirin initiatives. So Dr. Jody Abbott, who is at Boston Medical Center, and also the California Collaborative. And both of those groups said, yeah, Bayer wasn't really responsive. If this is something that you want to do, you're going to have to find your own avenue to get it. So my suggestion for that would be maybe partner with a local independent pharmacy that can order it for you and then sell it to you at a marginal markup. I find independents are usually a little bit easier on that type of stuff to work with. Otherwise, you'd be paying cash price for it. Now, you also have to remember that you probably will have to track lot numbers and all of that. And if there is a recall on that type of medication, those patients do need to be contacted. So that's just something additional to think about.
Yeah, that was my understanding. That was it in February that those new guidelines went into effect, that about medications that are distributed by a clinic, they have to keep track and all sorts of things. So it might be too challenging for clinics to take that on.
Yeah, I did see they bumped that up to 2024. But still, you know, I mean, how much are you going to buy? And then maybe the law goes into effect and then you're stuck with it.
Yeah. So
food for thought.
And it is easier to track if there are prescriptions. So yes, we can include the new guidelines in the notes.
Yeah, I actually did a CE on it because I have my my pharmacy tech certification, my national certification, and it's part of my CE every year that I have to do so many credit hours. And I actually did the CE on this. So I'll send the article to you that I did, or that I read through.
Thank you. Any other questions or comments?
I was just going to say, I also have some good news to share on the awareness campaign. So in September alone, there over 100,000 impressions were delivered for the display ads on the low-dose aspirin. We had over close to 300 website clicks, related social media, over almost 250,000 impressions delivered, 185 post engagement, and over 18,000 video views. So it's public showing interest, and they are looking at it. So that's good. And we're hoping to get them to the information that's being provided and to ask about aspirin from their provider.
Great. Thanks for sharing, Joyce.
Hey there, this is Heather Cox again with the Healthcare Authority. You mentioned the aspirin and the prescription limits, and I wanted to let you guys know that is something we are working on to have aspirin, low-dose aspirin be added to the exceptions so that it wouldn't count towards the 6 prescription limits. There's some other drug categories that we're looking at as well. We're just trying to develop a budget impact for all that right now, and you know how that can be kind of cumbersome. We aim to have that in our permanent rules, hopefully, fingers crossed, for this coming year, so it would be effective September of 2024. If we can come up with any other justification to make it sooner, we will do that. But that is something we're in the works. It's just with all the other things we're doing right now, and getting budget estimates for all of them. So I heard you say that and I was like, oh, wait, that is something.
Yeah. Well, and
wanted to-
there's a huge cost benefit for that. I mean,
Oh,
pay
absolutely.
for, less than $10, I imagine, over the entire course of somebody's pregnancy, and then you
Right.
don't
Aspirin is
have to
very
pay
cheap.
for those, the emergent care they may need, the preterm birth and the stay in the NICU, the lifelong health complications. I mean, yeah,
Yeah,
it's
that's
a
definitely-
cheap way to make an impact.
Yeah, and especially with the move to managed care, the people who are going to be left on the fee for service, they may be the higher need. They need more prescriptions, so we want to find ways to make everything better for them. So, but also it is not officially official yet, but I was just letting y'all know that it's something that we're working on.
Well, thank you so much for sharing that. I appreciate it.
And then whenever
That's
we
exciting.
do put that out and we put public notice for public comment, please, write some comments in support. We appreciate that.
Yeah, let us know when that is and we can share that. So people
Yeah,
can-
we love positive comments instead of just negative ones.
Yeah, well, we could get a lot of positive comments, so let us know when that comes out and we can share.
Certainly will. Thank you.
Thanks, Heather. Thank you so much, Melissa. We appreciate that. And Melissa is available to come to your clinic and talk to whoever, all of our partners. And if you deal with pregnant people, she can give you all of the tools that we have. And all of this is on our website at opqic.org/LDA.
Thank you, guys.
Thanks, Melissa. I wanted to add this just to remind everyone about the maternal mental health hotline. The number changed. So this is the new maternal mental health hotline. We do have flyers and things that you can print on our website. So I think this is something that everyone should be aware of. So please ensure that all of your patients are aware of the National Maternal Mental Health Hotline. And Denise?
Sorry, my mute button was eluding me. We just wanted to make sure we have provided in the past some of our OMNO data reports. Our most recent one that was released was data regarding Q1 of 2023, but all that one and all of our previous data reports are available on the OPQIC website. You see the link here, and I'll also drop it into the chat. But for those of you who are aware of our OMNO initiative, this is for hospitals that have been participating with Oklahoma mothers and newborns affected by opioids. And they submit case-by-case data to us, and we have a beautiful aggregate report available that displays those data. So feel free to peruse if you're interested.
Thanks, Denise. And any other questions or other business? Well, the next slide, I think we had a couple of other just updates. If you'd like to attend our quarterly meetings, this is the link to register, and you can get that added to your calendar. So make sure if you register for a meeting, you just sign up to be added to all the upcoming quarterly meetings so that you don't have to worry about it again. Our next meeting will be in January on the 16th, and then April the 16th also, coming up next year. And we also wanted to remind you again of our pre-summit and our summit. If you haven't registered, please register, and remind you also of the OSU Project Echo Maternal Health events that take place the first and third Thursday of every month from 12 to 1. And if you go to the Oklahoma State Echo website, if you just Google that, you can find it. And this is the Maternal Health Echo that we'd like to ensure that you all join us. And so thank you all for joining us this evening. And I hope everyone has a nice evening and rest of your week.